Good afternoon, everyone. We will we are excited to present today on deep vein thrombosis and pulmonary embolism. This presentation's recording will be available on our Blue Cross Blue Shield Provider Risk Adjustment webpage. Throughout the webinar, the Q&A box will remain open for you to submit your questions. We will answer all questions pertaining to the webinar's topic in an email when we send out your CEU certificate. If we are unable to address your question during the session, a response will be emailed to you after the webinar. This presentation has been approved by the AAPC for 1 CEU credit. Please note, you must attend at least 75% of the presentation in order to be awarded your certificate. After attendance has been verified, certificates will be emailed to you with your email address provided within the registration link. This presentation is intended for both physician and office staff. The information contained in this presentation and responses to the questions are not intended to serve as official coding or legal advice. All coding should be considered on a case-by-case basis and should be supported by medical necessity and the appropriate documentation reflected within the medical record. Before we begin, I want to take a moment to introduce our risk management team and some of our presenters for today. Our team is comprised of nurses and coders that have worked in an array of settings with many years of experience. I'd also like to outline some goals we have for today's webinar. Our goal is not to make you experts with DVT coding, but we are hopeful you will leave feeling more confident in coding for DVTs and pulmonary embolisms. Before we begin, let's gauge everyone's comfort level with DVT coding. The poll is being launched, and if you could add how well you know this type of coding from extremely well to extremely not well. All right, so I'm going to turn things over to Missy to get us started.
Thank you, Tracy. Good afternoon. Let's dive in and learn more about deep vein thrombosis and pulmonary embolisms. Deep vein thrombosis is a condition where a blood clot forms in a deep vein, typically in the legs. It can be serious if the clot breaks loose and travels to the lungs, causing a pulmonary embolism. The clot can block blood flow and cause swelling, pain, and warmth in the affected limb. Recognizing the signs and symptoms of a deep vein thrombosis or DVT is crucial for early diagnosis and treatment. Here are some key indicators. One of the most common symptoms of DVT is swelling in the affected limb, usually in the leg. This swelling may occur suddenly and can be significant. Pain or tenderness in the affected limb, particularly in the calf or thigh, is another common symptom. The pain may start as a cramp or soreness and can intensify over time. DVTs can cause noticeable change in skin color. The skin over the affected area may become red or take on a bluish hue. These color changes are often accompanied by warmth and may be mistaken for other conditions. Being aware of these signs and symptoms can lead to prompt medical evaluation and intervention, reducing the risk of complications such as pulmonary embolisms. Let's explore how to evaluate and manage this condition effectively. Diagnosing DVTs involves a combination of clinical assessment, imaging tests, and laboratory studies. When a patient presents for symptoms suggestive of DVT, such as leg swelling or pain, healthcare providers conduct a thorough physical examination to assess the severity and location of symptoms. Imaging studies play a pivotal role in confirming the diagnosis. Duplex ultrasound is the primary imaging modality used to visualize blood flow in the affected veins and detect the presence of blood clots. This non-invasive and readily available test offers high sensitivity and specificity in diagnosing DVTs. In some cases, additional imaging studies may be warranted to evaluate the extent of the clot or identify potential complications. These may include venography, MRIs, or CT venography. Once a diagnosis of DVT is confirmed, prompt initiation of treatment is essential to prevent complications such as pulmonary embolism and long-term complications like post-thrombotic syndrome. Throughout the treatment process, ongoing evaluation and monitoring are essential to assess treatment response, detect complications, and adjust therapy as needed. Regular follow-up visits and imaging studies help ensure optimal management and reduce the risk of reoccurrence. Diagnosing and treating DVT requires a comprehensive approach that integrates clinical assessment, imaging studies, and evidence-based therapies. By leveraging timely diagnosis, appropriate treatment strategies, and vigilant monitoring, providers can effectively manage DVTs and improve patient outcomes. Once the DVT is confirmed, prompt initiation of treatment is crucial to prevent complications and promote recovery. Anticoagulants, these are medications. They are a mainstay of DVT treatment. They work by preventing new clots from forming and reducing the risk of existing clots enlarging or breaking off. Commonly prescribed anticoagulants include heparin, warfarin, and direct oral anticoagulants. They require careful monitoring of blood levels and dosage adjustments to ensure efficacy and safety. Thrombolytics, in some cases of extensive DVT or when there's a high risk of limb-threatening complications, thrombolytic therapy may be considered. Thrombolytics are powerful drugs that dissolve blood clots quickly, restoring blood flow to the affected area. However, they can carry a higher risk of bleeding complications and are typically reserved for severe cases or when other treatments have failed. Inferior vena cava filter for patients with contraindications to anticoagulant therapy or recurrent DVT despite adequate treatment, placement of an IVC filter may be considered. This small cage-like device is inserted into the inferior vena cava to trap blood clots before they can reach the lungs and cause a pulmonary embolism. Compression stockings. These are specialized garments that apply gentle pressure to the legs, promoting blood flow and reducing swelling. Compression stockings are often recommended as part of the DVT treatment and prevention strategies. They help alleviate symptoms, prevent complications like post-thrombotic syndrome, and may be used in combination with other treatments. It's important to individualize treatment based on the patient's factors, such as the clot size, location, comorbidities, and bleeding risk. Multidisciplinary collaboration among healthcare providers, including hematologists, vascular surgeons, and interventional radiologists, ensures comprehensive and effective management of DVT. Now let's look at some practical tips to help reduce the risk of developing a deep vein thrombosis. On long flights, it's important to stay active. Get up for a walk every hour or so. This helps keep your blood flowing and reduces the risk of clots forming due to prolonged immobility. Consider wearing compression stockings. These stockings apply gentle pressure to your legs, which helps improve the blood flow and reduces the likelihood of clot formation. If you're sitting for long periods of time, such as during a long car ride or while working at a desk, you can boost circulation by doing simple foot exercises. Pump your feet to enhance blood flow. Stop smoking and stay hydrated. Smoking restricts blood flow and increases risk of blood clots. Drinking enough water can help keep the blood flowing. Now we'll talk about pulmonary embolisms. A serious complication of a DVT called pulmonary embolism occurs when a blood clot from another part of the body, often from a DVT in the leg, travels to the lungs and blocks one or more pulmonary arteries. This blockage can restrict blood flow, reduce oxygen levels in the blood, and put strain on the heart and lungs. Symptoms of a pulmonary embolism can vary in severity, but common signs include sudden shortness of breath, chest pain that may become worse when they breathe deeply, cough, or lie down, rapid heart rate, coughing, which may produce bloody or blood-streaked sputum, feeling lightheaded or dizzy, and excessive sweating. Some common risk factors for pulmonary embolisms are immobility, prolonged periods of inactivity, such as long flights or bed rest during recovery from surgery. They can increase the risk of blood clots forming in deep veins, which can travel to the lungs. Surgery, a particular major operation like orthopedic surgery, can cause tissue damage and lead to clot formation. Cancer is another significant risk factor. Certain types of cancer, as well as chemotherapy, can increase the likelihood of blood clotting. Trauma or injury to the lower limbs can damage veins and lead to clot formation, which can migrate to the lungs. Pregnancy and the postpartum period are times of increased risk due to changes in blood flow and hormonal influences that make blood more prone to clotting. Certain medical conditions, such as heart disease, stroke, or inflammatory bowel disease, also elevate the risk. Hormone therapy or birth control pills that contain estrogen can increase clotting tendencies, particularly in women with other risk factors. Lastly, genetic factors such as inherited blood clotting disorders can significantly raise the risk. Being aware of these risk factors allows for better management and prevention strategies, especially for individuals who might be at a higher risk due to conditions or situations. Let's review the main consequences of pulmonary embolisms. Pulmonary embolisms can cause permanent damage to the affected lung. The blockage of a pulmonary artery can lead to lung tissue death due to lack of blood flow, resulting in lasting damage. PEs often lead to low levels of oxygen in the blood. When the blood flow to the lung is obstructed, it hampers the lung's ability to oxygenate the blood, which can cause hypoxemia. This reduction in oxygen can damage other organs in the body. Organs such as your heart and brain, which rely heavily on a constant supply of oxygen, can suffer damage from prolonged periods of low oxygen levels. Pulmonary embolism is a major cause of mortality. It is responsible for over 100,000 deaths each year in the United States alone, highlighting the severity and often fatal nature of this condition. Accurate and timely diagnosis of pulmonary embolism is key for effective treatment. Here are the primary diagnostic tests used. We have the CT pulmonary angiogram, CTPA. This is the most definitive imaging test for PEs. It involves injecting contrast dye into the blood vessels and using CT imaging to visualize any blockages in the pulmonary arteries. Next is the D-dimer blood test. This test ensures the presence of a substance that's released when a blood clot breaks up. Elevated D-dimer levels can indicate the presence of an abnormal blood clot, making it useful initial screening tool, although it is not specific to pulmonary embolisms. The chest X-ray is often performed to rule out other conditions with similar symptoms, such as pneumonia. While not definitive for pulmonary embolisms, it helps provide a broader picture of the patient's lung health. The arterial blood gas test, or ABG, measures oxygen and carbon dioxide levels in the blood. In the context of PE, an ABG test can reveal low oxygen levels and other abnormalities that suggest impaired gas exchange due to blocked pulmonary arteries. Each of these tests plays a specific role in the diagnostic process, from initiating screening to definitive confirmation of pulmonary embolism. Understanding these tests helps ensure accurate and efficient diagnosis, leading to better patient outcomes. Here are the main treatment options for pulmonary embolisms. Anticoagulants are used to prevent further clot formation. Common drugs include heparin, warfarin, and direct oral anticoagulants. The vena cava filter is a small device inserted into the inferior vena cava, the large vein that carries blood from the lower body to the heart. It is used to prevent blood clots from traveling to the lungs. This option is typically considered for patients who cannot take anticoagulants. Next is pulmonary embolectomy. This surgical procedure involves the removal of the blood clot from the pulmonary arteries. It is generally reserved for severe cases where other treatments have failed or are not suitable. Fibrinolytic therapy involves the use of clot-dissolving medications, also known as thrombolytics. These drugs help to rapidly break down the clot. This therapy is usually used in life-threatening situations or in cases of massive pulmonary embolisms. Lastly, percutaneous thrombo, thrombo, thrombectomy is a minimally invasive procedure that uses a catheter to physically remove the clot from the pulmonary arteries. It is an alternative to surgery and can be used in patients who are not candidates for the fibrinolytic therapy. Each of these treatments is chosen based on the severity of the PE and the patient's overall health, with the goal of restoring normal blood flow and preventing further clot formation. Reducing the risk of pulmonary embolism starts with preventing DVT, which is the primary cause of PE. Here are some important tips. Exercise your lower leg muscles if you're sitting for a long time while traveling. Regularly flexing and extending your ankles and knees can help the blood flow to your legs. Get out of bed and move around as soon as you're able after having surgery or being ill. Early mobilization is important. The sooner you start moving, the better your chances of avoiding a blood clot. The movement stimulates blood flow and prevents stagnation. Take, take medicines to prevent clots after some types of surgeries, as your doctor prescribes. Certain surgeries, especially those involving the hips and knees, significantly increase the risk of DVT. Anticoagulant medications prescribed by your doctor can help prevent clot formation during the recovery period. Knowing whether you're at risk for DVT and taking these steps to lower your risk are essential in preventing both DVT and pulmonary embolisms. By incorporating these practices, you can significantly reduce your chances of developing these these dangerous conditions. Now I will hand it over to Jacqueline.
Thank you, Missy. Now that you have heard the common signs and symptoms of DVT and PE, the tests involved to assist providers in making a diagnosis, types of treatment, and what can be done to prevent deep vein thrombosis and pulmonary embolism from happening, next we'll take a look at a few coding scenarios. John Smith, a 55-year-old male, presents to the emergency department with severe pain and swelling in his left leg. He has a history of hypertension and recent long-distance travel. After evaluation and an ultrasound, a DVT of the left lower extremity is confirmed. What would you code for this scenario? The correct codes are I-82.402, which is acute embolism and thrombosis of unspecified deep veins of the left lower extremity, and I-10 for essential primary hypertension. Our next scenario, Sarah Davis, a 65-year-old female with a history of atrial fibrillation and recent hip replacement surgery, presents to the clinic with pain and swelling in her left leg. Ultrasound confirms an acute DVT in the left lower extremity with evidence of proximal extension into the iliac veins. What would you code for this scenario? You would code the following: I-82.422, which is acute embolism of the left iliac vein, I-48.91, unspecified atrial fibrillation, and Z96.642, presence of a left artificial hip joint. These scenarios demonstrate the complexity of medical coding for patients with the DVT and PE, requiring accurate documentation and code selection and treatment by the provider. For Z96.642, although it is not an HCC, it is important to include all diagnosis codes to paint the complete picture of the patient's condition. Here's our next scenario. A patient, 45-year-old male, presents for follow-up INR after unprovoked pulmonary embolism 5 months ago. The patient is currently asymptomatic. His exam was within normal limits, and he continues on warfarin for a 6-month course. What would you code for this scenario? The diagnosis codes for this scenario are Z86.711, personal history of pulmonary embolism, and Z79.01, which is long-term current use of anticoagulants. This is the rationale for that scenario. Per the 2024 ICD-10 official guidelines for coding and reporting within Chapter 21, Z79 long-term current drug therapy, the codes from this category indicate a patient's continuous use of a prescribed drug, including such things as aspirin therapy, for the long-term treatment of a condition or for prophylactic use. It is not for use for patients who have addictions to drugs. Assign a code from Z79 if the patient is receiving a medication for an extended period as a prophylactic measure, such as for the prevention of deep vein thrombosis, or as treatment of a chronic condition such as arthritis, or a disease requiring a lengthy course of treatment such as cancer. Here are a few coding tips. ICD-10 official guidelines for coding and reporting states the importance of consistent, complete documentation in the medical record cannot be overemphasized. Without such documentation, accurate coding cannot be achieved. And code all diagnoses that coexist at the time of the encounter or visit and that require or affect the patient's care, treatment, or management. This is going to present continuity of care, which is accurate and comprehensive records that ensure all healthcare providers involved in a patient's care have access to the same information. This is essential for coordinating treatments, monitoring progress, and making informed decisions. For patient engagement, a detailed record can empower the patient by providing them with clear and comprehensive information about their health status, treatment options, and progress. This can enhance patient engagement and adherence to treatment plans. For quality and safety, thorough documentation helps in identifying patterns, potential errors, and areas for improvement. This is key for maintaining high quality care and ensuring patient safety. Regarding billing and reimbursement, accurate records are necessary for proper billing and coding, which are required for insurance claims and reimbursement. Incomplete documentation can lead to denied claims or financial losses. For research and education, comprehensive medical records are valuable for clinical research and educational purposes. They provide data that can be used to improve medical knowledge, develop new treatments, and train healthcare professionals. Coding and documentation for chronic conditions. Active, efficient, and effective management of the chronic conditions is critical to ensuring that Medicare and ACA beneficiaries receive the best possible care and that these programs remain sustainable. Accurate and complete MEAT documentation of chronic conditions diagnosed by clinicians is an essential component of the risk adjustment and HCC process. M stands for monitor, documenting the signs and symptoms, disease progression, regression, and any ongoing surveillance of chronic conditions. E stands for evaluate, documentation of current state of chronic condition, physical exam findings, medication effectiveness, and response to treatment. A stands for assess, document of discussion of chronic condition, review of records, and counseling. T is for treat. That includes medications, referrals to specialists, diagnostic studies, and other plans for the chronic condition. Providers are required to document all conditions evaluated during every face-to-face visit. It is important to update the patient's past medical history and problem lists at each visit. Coding professionals should review the entire medical record documentation to assign appropriate ICD-10-CM diagnosis codes. CMS requires that all ICD-10 codes submitted to them be complete, truthful, accurate, and supported by documentation in the medical record. The OIG has identified deep vein thrombosis and pulmonary embolism as diagnoses under scrutiny by the OIG. DVT and PE fall into their high risk groups of diagnoses that are frequently miscoded. Clinical documentation required to support the correct code assignment indicates acuity. For acute, new symptomatic thrombosis at the initiation of anticoagulant therapy, chronic, which is old or established thrombosis managed with ongoing anticoagulation therapy, clearly state whether it is recurrent or chronic. For historical thrombosis or embolism that has resolved or may not be on prophylactic anticoagulant therapy. The location also needs to be stated, specify the vessel, location, and laterality. Indicate also whether it is provoked or unprovoked. For pulmonary embolism, specify with or without cor pulmonale. And for treatment, document treatment and goals of the treatment, example, preventive anticoagulant therapy or other therapies. These are some code sets that are commonly found with those two conditions for deep vein thrombosis and pulmonary embolism. In the I-82 code series, which is for embolism and thrombosis, veins unspecified and unspecified location, upper or lower extremity, laterality, severity, and other embolism and thrombosis. Examples of when to use this code category: patients seen for acute deep vein thrombosis of the left lower extremity starting warfarin treatment. So the code reported would be I-82.402. A patient presents to the primary care provider for management of chronic deep vein thrombosis of the right femoral vein, currently being managed with Xarelto. The codes reported should be I-82.511 and Z79.01. For the I-26 code series, pulmonary embolism with or without acute cor pulmonale, tight and septic emboli. The example here is patient seen for acute pulmonary embolism without cor pulmonale to begin anticoagulation therapy. The code reported should be I-26.99. I-27.82, which is for pulmonary embolism chronic. Patient presents for management of chronic pulmonary embolism and is currently on Eliquis. Codes reported should be I-27.82 and Z79.01. Z86.711, personal history of pulmonary embolism. Patient presents with a history of pulmonary embolism in 2016. It has resolved and no reoccurrence. Z86.711 is the code for that. Z86.718, personal history of other venous thrombosis or embolism. Example is patient at Coumadin Clinic to have an INR drawn. Previous deep vein thrombosis with no evidence of reoccurrence on ultrasonic imaging done 4 weeks ago. Remains on prophylactic Coumadin. Z86.718 as well as Z79.01 would be reported. And lastly, but not least, Z79.001, long-term current use of anticoagulants. This is reported when the patient is on a long-term anticoagulant. Document the reason for the long-term use. Do not assign the code from category Z79 for medication being administered for a brief period to treat an acute illness or injury. Now I will hand it back over to our host, Tracy.
Thanks, Jacqueline. Thank you all for joining our educational webinar today. Please feel free to contact us with any questions you may have related to deep vein thrombosis or pulmonary embolism coding. We have links provided here to our external website where you can register for upcoming webinars. Please provide your feedback on today's presentation using the QR code. Thank you to our speakers, Missy and Jacqueline, and we will see you next month for acute myocardial infarction and acute stroke coding.